Please welcome Dr. Casey O'Connell.
Hi, good morning. It's such a pleasure to be here. I'm really honored to have been invited, and looking at the excellent lineup that you have in front of you today, I wanted to present something that sort of didn't overlap too much with the other speakers, so I thought maybe we'd go over the treatment landscape, which I think is a really exciting one in this field and has an interesting history. So I'm calling the talk Pruning and Promoting the Landscape. So sometimes we have to cut things out, and sometimes we let things blossom. So from the physician's standpoint, the goals of therapy are to reduce thrombotic and hemorrhagic events in our patients with myeloproliferative neoplasms. Ultimately, we know after many, many years, there is a risk for transformation to more aggressive or more difficult to treat diseases like myelofibrosis and acute myeloid leukemia. So if we can make a stake in the disease and keep it where it's at and prevent it from progressing, we are extremely happy, although we're not quite there yet. We want to relieve symptoms in splenomegaly, although the literature suggests we're not so good at identifying the symptoms that you have. So you all, along with Ruben Mason colleagues, have really been wonderful at sort of promoting and vocalizing what the symptoms are that we should be asking about, because a lot of times these have been overlooked. And of course, in any disease, and especially in cancer these days, we sure would like to cure the illness permanently. This is a busy slide, but this is an update in our treatment algorithm for essential thrombocytosis and polycythemia vera. So really the big issues have become, how do we identify who's at very low risk and maybe doesn't need any treatment, and who's at very high risk? That's a little bit more obvious. It's the ones in the middle, low risk, intermediate risk. We don't really have a lot of very clear criteria on how to separate those. So in general, this whole group of patients with intermediate high risk need to have the blood cell counts reduced, because we don't want you to go on to develop thrombotic events, blood clotting, and those events seem to be linked with higher white blood cell counts and higher levels of the JAK2 mutation. So we are for sure using aspirin as a primary preventative strategy, usually cytoreduction with some sort of medication, and definitely phlebotomy for our polycythemia vera patients in whom we can use taking the blood out to get the hematocrit below 45. So remember when we only had hydrea. I just want to point out a little bit about hydroxyurea, because it really is still the treatment of choice, or the first line therapy, as we say in the medical community, for patients presenting with polycythemia vera and ET, and we even used it in myelofibrosis, and sometimes do still to this day. It's a ribonucleotide reductase inhibitor, so this is an enzyme that's part of how cells grow and replicate. And you know, we really have excellent long-term data for safety and efficacy of this drug, okay? It's a pill, and I think what really scares patients is that it's a chemotherapy drug. Any drug that gets in and stops cellular proliferation at that DNA level is considered chemotherapy. It's a cell kill. It's not very smart. It targets lots of different cells that are growing rapidly, and not just the cancer cells. And sure, that's a little bit intimidating. On the other hand, it's a pill. It has very few interactions with other medications. The side effect profile is shockingly minimal, considering it's a chemotherapy drug. But as you know, we're talking about acute problems with chemotherapy and acute things that we want to ask patients about. Patients often are struggling with really difficult long-term issues with hydroxyurea. Their hair gets thin, their nails get brittle, they start developing ulcers in the mouth, etc. And although to the oncologist, this may seem like no big deal because we're used to giving whopping doses of chemo and the hair falls out completely, or the patient has nonstop nausea and vomiting, to patients who are going to work and trying to live a regular life, we realize that these are serious problems, but it's all we had for a long time. So the reason I'm saying it's all we had, the hydroxyurea is represented on this green line, and this is a graph of the cumulative risk for patients going on to develop leukemia on a variety of medications. And these were the medications that we used to use that were very, very leukemogenic. So things like pepobromin and phosphorus, iodine, these were really toxic chemo drugs, and they all seem to increase the risk of leukemic transformation, whereas hydroxyurea looked way better than the rest of them. So that's how it became the standard of care, because what we were using prior to that was so toxic and seemed to add to the risk of patients going on to develop leukemia. So it's still considered first-line treatment in the US and Europe for PV and ET, although Europe does include pegylated interferon in their upfront treatment options. US does not. So let's move on from hydroxyurea. There's a lot of information about it in the literature. It's a great first option, but I'd like to talk about some of the other things that are out there, and starting with interferons. So interferons are actually natural proteins or hormones that your body makes, usually in response to some type of viral infection. And this slide shows a cell that's being infected with a virus, these little blue tennis balls here, and the virus has the ability to use your cell to replicate itself. But fortunately, as other cells, especially immune cells or other cells that might get infected, start to recognize that this is something foreign, you start to secrete these interferons. And interferons start a whole cascade of secondary reactions that help your body get rid of the virus. So they're anti-proliferative, they engage your immune system, a whole variety of reactions that you would normally have to a viral infection. So interferons have been around for decades. The original form was a little difficult because the body could get rid of it so quickly. So we used to have to give millions of units as a subcutaneous injection several times a week to patients. And as you can imagine, if this is a hormone you're making in response to a virus, when you keep injecting these very high doses of the interferon, the body's response was often to get sweaty and fatigued and have achiness and to feel like you had a viral infection. Now, we actually still have some patients who, for reasons not totally clear to me, want to stay on the old school interferon, but fortunately, longer acting forms that don't require such high dosing intermittently have come about, like pegylated interferon or Pegasus. And the French were the first to give us big studies on pegylated interferon for ET and PV. And what they showed, this actually is from a study here in the US by MD Anderson, but the data are very similar, is that the pegylated interferon for the treatment of ET and PV is relatively safe. So what do we mean by safety? People may have low-grade symptoms with the medication, but did they have to stop the medication because it caused something so toxic that we couldn't keep treating them? And when we use the lower doses, the number of patients who have to discontinue Pegasus is about the same as the number of patients who have to discontinue hydroxyurea. Around 15 to 20% can't tolerate the drug. They can't tolerate it for very different reasons than they tend to not be able to tolerate hydroxyurea, though. And in some of the studies, the discontinuation rate was much higher, but the French really learned a lesson from that because they had started at really, really high doses of the pegylated interferons, and they were losing patients because the patients said, I can't take this, I'm out of this study. So they changed the way they designed it, and they said, well, let's start low and then go up if we need to or go further down. So they sort of started in the middle, dosing-wise. And that's what we do at USC, and we've had excellent tolerability in our patient population, probably closer to the 15% end of things. And then what about efficacy? So these yellow bars represent the number of patients with PV in the first section, ET in the second, who were able to achieve what we call a complete hematologic response. So we got their blood cell counts to target. So if it was PV, we had the hematocrit below 45. If it was ET, we got the patients below 400,000 and controlled spleens in about 3 out of 4 patients. So this is excellent efficacy in our minds. Another smaller percentage had partial responses, so maybe with PV they still needed a phlebotomy here and there. And then there's a small percentage of patients, about 1 in 5, who doesn't respond to this medication. So we feel that it's effective in the majority of patients in terms of controlling the blood cell counts. What's more exciting is that it's got another level of effectiveness, reducing the JAK2 mutational burden. So can this drug do more than just control the counts? Can the drug actually reduce the number of cells that carry the JAK2 mutation? Because the paradigm has been set by a related disease, chronic myeloid leukemia, that has one mutation, and we know that if we can knock that mutation down below detectable levels, those patients live longer, do better, and now we're finding may even be able to come off of their therapies. So this is very exciting, and it looks like the pegylated interferon can reduce the amount of JAK2 mutation in about a third of the patients. And about 1 in 5 or 20% of patients can actually go into a complete molecular remission, meaning we can't detect this mutation anymore. So to us, that's been one of the most exciting developments over the last 10 years, aside from the discovery of the JAK2 mutation, is that we actually have a drug that in some patients we can make that mutation disappear. But not everyone can tolerate it, and we don't really yet have evidence to say that means they're going to live longer, or that means they're never going to develop leukemia. And that's a tough thing. We'll talk about that in a second, because it takes so long to figure that out. Okay, so we now have completed enrollment in a big national, and actually we have an international arm of this consortium called the Myeloproliferative Disease Research Consortium. And this trial, we said, let's look at whether we should start with maybe pegylated interferon instead of hydroxyurea, because all of the trials up until this point were generally for patients who couldn't tolerate hydroxyurea for some reason, or refused to take hydroxyurea for their own personal reasons. So this was a trial where the patients are randomized, so half of them unknowing, they don't get to make that decision, nor does their doctor. They get randomized to get hydroxyurea, the other half to get pegylated interferon. And so far, the rates of getting into a response in the first year look about, they're not statistically significantly different, but they don't look as good as the numbers I just showed you. So 53% for pegylated interferon, 69% for hydroxyurea. It does appear that the pegylated interferon treated PV patients had less requirement for phlebotomy, but these are very early data. We just completed enrollment and closed further enrollment back in the spring of this year, so just 5 months ago or so. Now we have to follow that whole cohort out for about 2 years, and then we can start to really say, you know, what do these data look like? So we're really excited to have been able to conduct this study. One sad or concerning note was that the company that was supplying the Pegasus actually said, you know what, we're done, and made us stop the enrollment when we did. So we're a little nervous about that, but there's another option behind door number 2, thank goodness, and that's called Ropeg interferon alpha 2b. This is another type of pegylated interferon, which can be administered every 2 weeks as opposed to every 1 week for the Pegasus. And so far, the data look really exciting with an overall response rate of 90%. And again, that's complete hematologic remission plus partial hematologic remission. The complete hematologic remission is about half of the patients. Again, as I mentioned, we're seeing some complete molecular remission, so JAK2 becoming negative. in about a fifth of the patients, which is really exciting. So it definitely is giving us that same signal that the Pegasus gave us. And it's already been demonstrated to be non-inferior to hydroxyurea and polycythemia vera. So hopefully, we will move toward having another option for patients who are getting Pegasus, especially if there's any concern that the company is not as interested in providing it anymore. Okay, now what about myelofibrosis? So that's for high blood cell counts. We talked about ET-PV with pegylated interferon. Myelofibrosis generally represents a disease where the hemoglobin is low. So most patients have low blood cell counts, at least with hemoglobin. Some may still have a high white count, high platelet count. Interferon has been tried in this group of patients as well. And the most exciting study was in 62 patients that were treated by the French groups in France and Belgium, where they saw 64% of the patients, 2/3 of the patients had improvement in their hemoglobin on treatment with this drug. So think about that for a second. We're giving the drug to people with polycythemia vera who have high red blood cell counts, or ET with high platelets, and then it's working to increase the hemoglobin. So it's decreasing the hemoglobin in the PV and increasing the hemoglobin in the myelofibrosis patients. So we really think that this drug is targeting the malignant clone. So when the bad clone of cells in that bone marrow is overproducing blood, it brings it down. When the bad clone of cells is causing underproduction of blood, it brings it down. It allows the good, healthy clone to come in and give us better red blood cell production. Now, that's not totally worked out scientifically, but that's our hypothesis. So that is extremely exciting. The majority of patients also experienced improvement in their constitutional symptoms, so things like bone pain and sweats. That doesn't tend to occur right away. In our data, that takes a little longer than, for example, it would with ruxolitinib. About half of the patients had a spleen response, which was qualified as just any improvement in spleen size, a little less stringent criteria than what was used in COMFORT with ruxolitinib. About 8% intolerance of the drug, so way lower than what other studies reported. One important thing that I absolutely use in my clinical practice when I'm trying to decide whether interferon could be a treatment option for a myelofibrosis patient is the only thing that predicted that the treatment wouldn't work in a myelofibrosis patient was if their spleen was greater than 6 centimeters below the left costal margin. So a very large spleen is a predictor that this is probably not a great drug for that patient. So that's really important to keep in mind. I teach this to the fellows. I still see them offering pegylated interferon to people with massive splenomegaly, and I say, oh, this is probably not a good idea, guys. So from a clinical standpoint, meaning just right in the office, we can figure this out. Your left rib edge, we measure how many centimeters below that edge we can feel the bottom of the spleen, okay? And so 6 centimeters is about 5 fingers down from that edge. So that would be considered. Beyond that, their patients in that group, really, those were the ones that didn't respond, which is really helpful, actually, because we don't want to expose the people to a drug that we know is very unlikely to work and could have side effects. Now, we had a much smaller study that we published last year, and what we were looking at was the same type of patients, but we wanted to show people what happens when you start this drug, because one thing that's very hard with this drug and many others, but this drug, especially when you compare it to ruxolitinib, is that it takes quite a while to have some of these exciting effects that we're talking about. So frequently, a physician in the community will say, yeah, we tried interferon, but geez, after 4 weeks, the white count went up, so we stopped it. Well, what we found was a couple of things happen. In the first 6 months, among the 5 patients who actually responded to the drug, we actually saw the white count go up, the LDH, which is a marker of blood cell production not being very smooth, the spleen size went up And so we have beautiful charts showing they went up, and then by 6 months, they all come back down to lower than where they started. And so 3 of the patients that had big spleens, their spleen size became almost undetectable. But what we also showed, which was a bit of a bummer and a little bit contrary to what was previously suggested by Dick Silver in New York, was that we saw no improvement in fibrosis. Fibrosis is a really tough thing, and I know it's come up, and I know you're reading about it, but one thing you have to realize is it's a totally subjective variable. There's a person looking at a stain who says, this is a lot of fibrosis. And so what we did is we took 3 different hematopathologists who all have experience in looking at marrows in patients with myeloproliferative neoplasms. We blinded them so they didn't know what each other had thought about the amount of fibrosis in these marrows. And we found there was variability, even among 3 people at the same institution who read these all the time. So what we did was we gave an average score of fibrosis for all of the patients, and on repeat marrows, we checked again to see blindly what these people thought about the marrow fibrosis over time. There was a little bit of improvement, but it wasn't as dramatic as had been previously reported. So I would highly encourage you, if you get a bone marrow biopsy report back that says something about fibrosis, I would ask for a second opinion on the bone marrow biopsy. So when you ask for a second opinion from your physician, or you talk to friends and someone says, so-and-so is a great doctor, that's actually different than asking for a second opinion on the bone marrow biopsy. That comes from a pathologist. And you're allowed to do that. You're allowed to ask your physician who performed the bone marrow biopsy or who is giving you the results of the bone marrow biopsy, hey, could you ask if they could send that to another hematopathology expert in myelofibrosis or in myeloproliferatives and see what they say? Because I've had some people who have a non-cancerous proliferation of cells that we do a bone marrow biopsy and there's some fibrosis, and they actually don't have a myeloproliferative neoplasm. And my pathologists say a little bit of reticulin fibrosis is okay, it's normal. So we have to be really careful about scaring you with this fibrosis thing until we're really sure that multiple people agree that it's there, okay? Yes? Opinion, yes. Usually it is, and they won't do it unless it's covered. So they will ask for authorization, and the receiving, just like if I was receiving a patient, but my hospital at the USC says this patient's insurance won't cover this appointment, then we're going to have to figure something out or ask for an appeal. The same thing would happen with the pathology. They will first ask for the authorization. Yeah. All right, so as mentioned previously, in 2005, we had this exciting new discovery, JAK2 mutation. I will say when I was a fellow, before this all happened, the landscape in myeloproliferative neoplasms was very arid and dry. There was really not much. It was very hard to be a physician in a field where we had 1 or 2 medicines that sometimes sort of worked, especially when it came to myelofibrosis. PV and ET, since they responded 85% of the time pretty well to hydroxyurea, that was a little easier. But there were still people clamoring for other options, and we didn't really have anything to provide. So once this happened, this breakthrough, yes, there's a mutation. Yes, we know what the pathway is. The whole landscape really opened up and has been so exciting, as mentioned before, both to be a physician and also to be able to counsel patients. So the JAK2, what does that mean? It's a receptor on cells, progenitor cells in your bone marrow that are just waiting for a signal to be turned on. And the signal usually comes in the form of some kind of hormone in the body. So when JAK2 gets turned on, you'll make more blood cells, but you'll also have all sorts of other potential inflammatory type cytokines or hormones that may come out as a result of this overdrive on JAK2, on the JAK receptor. So the interesting thing is, especially in myelofibrosis, but also in the other disorders, this pathway is really active even when it's not mutated. So that's why ruxolitinib can work in myelofibrosis even when there isn't a JAK2 mutation per se, because the pathway is still controlling the proliferation or the oversecretion of those cytokines. So once we knew that this was the pathway and we knew that there was a very prevalent mutation in that pathway, we could start to say, wow, let's inhibit the pathway. We figured it out. Now, what little drugs could we use to stop activation of the pathway along the way? And, you know, there's a whole bunch of them now, which we didn't have before, and they're listed here. So we're really excited, and it turns out that that pathway is active in rheumatoid arthritis, and we have a drug that works on this pathway that's already FDA approved for rheumatoid arthritis. It's called Xeljanz, Xeljanz, Janz. Don't go tell everyone, or don't go tell your doctor, but it seems like it also makes the hair grow back. So if you look up JAK inhibitor under Google Images, the first thing that comes up is people with baldness showing that their hair grew back. Shh, that's a secret. Okay, so the first big studies that resulted in the first JAK2 or JAK inhibitor drug were Comfort 1 and 2. We participated in Comfort 2 here in the United States. And this led to the approval of ruxolitinib for intermediate high risk, primary, post-intermediate or high risk, primary myelofibrosis occurring after PV or ET. Patients had an excellent response in terms of the big spleen. So that has really become a bar set by this trial. Spleens shrunk, and they shrunk quickly. They shrunk within weeks, which we had never seen before. Hydroxyurea can shrink the spleen a little bit, but this was dramatic. It was really noticeable. Patients were it was so gratifying to be part of this clinical trial. And the spleen response lasted, but over a couple of years, some people began to lose that response, so we still need more options. These are hemoglobin levels and platelet counts, and ruxolitinib is here with these little diamonds. Best available therapy is these little squares. That's the people who didn't get the ruxolitinib right out of the gate. So here we have the mean hemoglobin. So our big problem, as many of you probably know, with ruxolitinib is it drops the hemoglobin. And on average, that's going to go down by about 1.5 grams. So this was a real tough thing for us, because if you had a myelofibrosis patient with about 8.5 grams of hemoglobin, they were going to end up transfusion dependent on this drug. Now the good news was that after 12 to 24 months, we actually started to see an improvement in the hemoglobin, at least almost back up to their baseline, but it never really exceeded where the patients started. So it didn't fix the anemia. It actually made it worse, and then maybe allowed the hemoglobin to get a little bit better over time, but it didn't make the hemoglobin get better than where the patients started. So that leaves a real area for us to work on. And then this was platelet count. And the ruxolitinib also decreased the platelet count, and in many of the cases that was okay, because some myelofibrosis patients started with high platelet counts. But for those who started with low platelet counts, especially below 50,000, this really wasn't a trial for them. Ultimately, what we learned, and what really has been just such a gift to us all, is that ruxolitinib ended up leading to a survival benefit in the patients treated. They lived longer. And so that was really exciting. But the interesting thing was, it wasn't because they didn't go on to get leukemia. The same number of patients evolved to acute myeloid leukemia in the Rux group as in the best available therapy or placebo group. And so we started to sort of hypothesize why that might be. Well, many of the patients were very, very sick at the outset, very wasted, loss of muscle mass, probably unable to tolerate an infection or another usual hit that might occur in their lives. So moving on from ruxolitinib, what about building on it? So in CML, we had Gleevec, and then we had all kinds of other drugs that seemed to keep getting a little bit better or having another little niche to fall into. So we presumed that that would be the pathway for the JAK inhibitors as well. And look at some of the headlines. Updated. In another big cancer setback, Sanofi shuts the fedratinib program down, Fierce Biotech, 2013. We were in that study, and I was on vacation in Hawaii when I got the call. We're closing it down, take everybody off. We've had these cases of a certain type of neurotoxicity. It was only a handful of people. Many other people were benefiting. The company did not want to take it a step further when these 5 or so cases were identified. Another drug we participated in the clinical trial for that I was so excited about, momelotinib. Future of momelotinib in myelofibrosis uncertain after phase 3 update. This was just last year at this time. So unfortunately, momelotinib was going to be the JAK2 inhibitor or the JAK inhibitor that resulted in improvements in hemoglobin. And actually, the patient I had on that trial before it got closed, actually I had on the phase 2 trial that occurred after the phase 3, became transfusion independent on the drug. I thought it was great. It didn't shrink his spleen to the same degree that Rux shrunk my other patient's spleen, but for him, transfusion dependence was a much bigger issue than his spleen was. But unfortunately, the endpoints that were set up on those phase 3 trials were all about the spleen because they really had to mimic what had been done in ruxolitinib. And so they didn't meet their endpoints. And so I don't think momelotinib is going to go forward, but maybe someone else will buy it and look at how it works in anemia. Here we're talking about rodents. So this is a study in rodents where they were trying to figure out how does the hemoglobin get better, and it seems like it may have an effect on a hormone in the body called hepcidin. City Biopharma updates on the pacritinib trial. We also participated in this one and suddenly got a call that the FDA put the whole trial on hold, and we had 3 or 4 patients still on study at the time. We had to take the drug away from them. The Europeans were incensed because a lot of people get really sick when you stop giving them their JAK inhibitor. But the FDA made this happen, and ultimately, they released the clinical hold. They said, oops, actually what we thought was going on with increased deaths was not going on, and everything's fine, and so why don't you just do another trial, look at some other dosing of the drug. So I don't know what's going to happen. These companies spend millions and millions of dollars to get to this point. When they take a hit like that, you know, it's hard to know if they will continue the high-risk potential, not so high reward equation into the future. So that was sort of, uh-oh. Did I do something wrong? Ah, there we go. Okay, what about JAK inhibitors that might be here to stay? Well, obviously, we've got the Rux. Pacritinib, I think there might still be hope. They're still doing this phase 2 trial. I think City of Hope decided to participate, right, Dr. Snyder? And then there are some other ones. There's one called NS018, which is kind of interesting because rather than just blocking that JAK pathway I told you about, it's meant to just block the mutated JAK. So maybe that will do something like more reduction in the JAK mutation burden, but at least in the phase 1 trial, so very early, we're seeing really good shrinkage of the spleen, symptom response, and the side effect profile looks pretty similar to Rux with cytopenias, dizziness, mild things for the most part. There's another, it was just reported, called gandatinib. I think that I might have switched those. Also still in phase 1 with 62% of patients showing a more than 50% shrinkage of their spleen. The strange thing with this one is that they saw some tumor lysis, which means that the drug is hitting the target so well that cells are dying really rapidly and releasing some toxins. And one of the results of releasing a lot of toxins from dying cells all at the same time is patients can go into kidney failure. So they had 5 or so episodes of that. They went back, redesigned the trial to start with lower doses and lead up to the full dose. That seems to be working, but you know, these are still early phase trials, so let's see what happens. But this does seem pretty promising. And then unfortunately, it's got a little more GI toxicity, kind of similar to the fedratinib and the pacritinib with diarrhea and nausea. So what's on the horizon? Does anyone watch this show? I love this show. I've seen every single episode. But I also loved Golden Girls, so it's probably kind of weird. But has anyone seen this, Frankie and Grace? Okay, I'm not going to talk about what this is a picture of. You know if you've seen the show. So, agents in early development for myelofibrosis. Imetelstat is a telomerase inhibitor, which seemed really exciting. So, telomeres are strands of DNA that are on the ends of your good DNA that replicates. And every time your DNA replicates, your body needs to attach these little strips on the ends to protect the DNA. We believe that as we age, shorter and shorter telomeres result in our wrinkles and our saggy skin. But we also know that some cancers have the ability to put telomeres on their own DNA, their bad DNA, the DNA we don't want to be saving and replicating. We want to be able to chop that bad DNA up. So this is an inhibitor of the enzyme that the cancer might be using to lengthen its telomeres and protect itself in the DNA. Unfortunately, the phase 1 data looked really exciting. The phase 2, they've decided to let the people who are already getting the drug continue on the drug. And there are some people that have been on it for years, and there are some really exciting responses. There were some concerns about toxicity, particularly low blood cell counts. So we're going to have to see what the company decides. They may not decide to go forward with it because of the toxicity issues, or they may decide to focus more on the high blood cell count patients. But we're going to have to keep an eye out for things like other cancers and stuff because of the mechanism that's very complicated in telomere biology. There's also another agent that seems really exciting called PRM-151. This is an anti-fibrotic agent. It was being studied to see if it could work in liver cirrhosis, where there's also lots of fibrosis going on that makes that organ fail, similar to myelofibrosis, where the scar tissue makes the organ fail. So it's been tested in those sorts of diseases. There's some promising phase 1 and 2 data for our patients with MPNs. So we're really kind of hopeful that we'll hear more about that in the next year or two. Then there's another one, LCL-161, a SMAC mimetic. I won't go through all of that. There's some promising phase 2 data there. So there are some things happening in myelofibrosis that really could lead to some more options for our patients, which is exciting. I feel that a real area of unmet need is our anemic myelofibrosis patients, as I mentioned before. So we use pegylated interferon, but for patients with a very large spleen or who can't tolerate the Pegasus, what can we do? So some people have used danazol. Danazol is an old medicine that I thought was voodoo when I was a fellow, but it was kind of all we had. So we gave it to lots of people with low blood cell counts, and it worked like 5% of the time. We now know why it works. It actually lengthens telomeres, doing the opposite of what the imetelstat does. A little interesting. So that's being used sometimes off-label and not on a trial. So tadalafil is a really exciting drug. You may have heard of luspatercept, also a little further in clinical trials, but this is the same concept. It does something with TGF-beta, which is one of the signaling enzymes that leads to red cell maturation and is trapped in some of our patients. And so by unleashing the trap, you can get some of the red cells to start to develop. It's already being evaluated in thalassemias, and so MDS and MF are a good second area. We looked at a 36% hematologic improvement in phase 2, which is on par with something like Revlimid, not as good as what we saw with the Pegasus from Europe, but there's an ongoing trial, and usually in phase 1 and 2, you're dealing with much sicker patients who've already had many, many therapies. I mentioned the momelotinib, which I feel would be something we should hang on to for anemia. The response rate in the trial was 53%, not bad, with a little spleen shrinkage, just not as good as Rux. So something to think about. Is there a cure? We'll hear more from Dr. Snyder about stem cell transplant. And can cytogenetic or complete molecular remissions, could those maybe lead to permanent disease-free states in some of our patients? Unlikely in myelofibrosis, but maybe in polycythemia vera or ET, earlier diseases. We'll see with myelofibrosis. We have an ongoing group of patients that we're monitoring this in, and with the interferons, but also maybe with some of the targeted agents for the actual mutation. We may get to see some molecular remissions in that group as well. Okay, that's a lot. I just want to put out a couple of comments about what I see as the issues in getting us new options. So spleen size reduction, I sort of mentioned, but it's not universally applicable. Not every patient with myelofibrosis has a massive spleen, and yet the FDA is now sort of setting that as the standard for our trials, and we can't even enroll patients with myelofibrosis in any of these trials unless they have a big spleen. So we may be losing treatments too that would benefit a subpopulation. Like we might lose momelotinib, and hopefully with your advocacy, you guys can make a voice for that. Because, yeah. Mm-hmm. Yep. Momelotinib. Well, the problem is because the FDA set the spleen thing as the number one endpoint, everybody on the trial had to have an enlarged spleen, and they failed to meet that endpoint, even though a secondary endpoint was, let's see if it gets the hemoglobin up. And it did, but that wasn't considered important. It wasn't the primary endpoint. So I feel this is a big problem in drug development for these diseases. No, this trial, all of the work on the momelotinib was with that drug by itself, and it was being compared in the big trial to ruxolitinib or best available therapy. Then we went and did a phase 2 where we tried to figure out, well, maybe we can show that it improves anemia, and show how that happens. That's what the FDA gave the bone to the company, but I don't know what's going to happen. I didn't get very positive news, but I don't want to spread rumors until we know for sure. In PV and ET and myelofibrosis, but more so in these diseases, we really don't understand why people clot. We don't understand why they clot in their liver. We don't understand why they're clotting in strange places. We've got to get to the bottom of that so that we can help those patients that are affected in that way. We don't even know if anticoagulation choices, if one's better than the other. Should we be using Xarelto? Should we stick with Coumadin? This is an area that really needs some more attention. And when it comes to PV and ET, as you know, we need long-term follow-up because a drug could look great for the first year or two, and not until year 15 do you find out, well, it's ruined my hair, it's causing me these other problems, or now I've picked up a new mutation that I wouldn't have had on a different drug. We really don't know. So we have to try to clamor for even just some minimal follow-up in these trials. Even in the MPDRC, we just don't have the money to follow these patients. But I'm going to want to know in 10 years how PV did better with HU or interferon. 2 years, that doesn't tell me that much. I know interferon takes a long time to really bring those mutations down. And I think that's it.